So, good afternoon, everyone. This session was everything you wanted to know about treatment, but were afraid to ask, a primer for non-clinicians. This came about because of a question last year when we were doing a discussion of the film Anonymous People, and the question was, what does treatment for alcohol use disorder look like? And while the panel at the session did an admirable job of answering the question, there really wasn't enough time to explore this in any detail. So our aim today is a first of its kind workshop at RSA to provide brief descriptions delivered by experts in the field of treatment research and recovery research, and of the major facets currently available for the treatment of alcohol use disorder. So, I just want you to realize how I came to understand that this is an important issue. And I actually spent 5 years working at a treatment facility in Del Mar, California, giving lectures to the clients. They had another word for themselves, who were in there for a 30-day detox about what happened to their brain. But I think I learned more from them than they learned from me. And it was a really interesting experience, which has shaped much of my thinking about treatment since. So we've organized this session around 5 questions, and we're fortunate enough to have national experts in the treatment field to address them. These are the 5 questions up here. How do you know someone that needs treatment and decide what's next? And Richard Sates is going to talk about that. What kinds of behavioral treatments are delivered in treatment programs? And Carrie Wilkins will address that. What medications are used to treat alcohol use disorder? Barbara Mason will discuss that. What does the treatment system look like, and who pays for treatment? And Kim Johnson will address that. And what do mutual help groups play? What role do mutual help groups play in the treatment of alcohol use disorders? And Keith Humphreys will address that. And I want you all to realize that these 5 people have worked their whole lives in the domains that they're going to be talking about. They are some of the world's experts in these areas. And as I introduce each one of them, I'll tell you where they're from. So I'd like to get started, and we're going to start with you, Richard. And Richard is a professor at the Boston University School of Public Health Department of Community and Health Sciences in Boston, Massachusetts. And he's the editor of the Journal of Addiction Medicine.
I had big shoes to fill on that one, George. Thank you. How do I find where I am? No. Yeah. Oh wait.
Yeah, we can close that.
Here we go. Correct?
Yep.
You're right. The mouse is really weird.
It is really weird. Yeah.
Thank you. So, how do you know someone needs treatment and decide what's next? So, to get to that, I want to begin with what it is that we're talking about and start with the idea that not everyone has an alcohol use disorder. Now, not everyone drinks. Also, not everyone who drinks has an alcohol use disorder. Not everyone who drinks too much has an alcohol use disorder, but some people who drink too much have an alcohol use disorder. So let me spend a little bit of time on this next slide, which is a graphic that I'll describe for those of you in the back, and I'll tell you what the small words are if you are in the back and can't see them. So I think what we're concerned about largely from a health perspective is in people who drink, those who I might describe as having unhealthy alcohol use, or alcohol use that affects some part of their health, some has some health consequence. And that spectrum could go from risky use, and that would be the bottom part of this triangle here, to alcohol use disorder. Let me describe the triangle again. The whole triangle is supposed to represent all possible states of alcohol use. The bottom is abstinence, not drinking at all. somewhere between 20 and 35% of adults in the US, depending on whether you ask them about last month or last year. Then low-risk use or lower-risk use, because it's not clear that there's use with zero risk, especially since alcohol is a known carcinogen. So there's low-risk use, and then up here in the orange triangle, this is what I'm calling unhealthy use, unhealthy alcohol use. And unhealthy alcohol use, I would really divide in your minds into two big chunks. The top chunk is alcohol use disorders, a disease, a diagnosis, a condition. And the bottom chunk here, this more orange part of the triangle, is risky use, or at-risk drinking, or hazardous drinking. This top part called alcohol use disorders, I'm using terms that we use in the US from the Diagnostic and Statistical Manual of Mental Disorders, the DSM. Internationally, you might see the International Classification of Diseases, and they would break down this disease part or condition part to dependence and harmful use, dependence being more severe. The American Psychiatric Association abandoned dependence in large part because it was often confused with physical dependence and not the syndrome that constituted a disorder. Now, this disorder, alcohol use disorder, is often characterized as mild, moderate, or severe. And if you look in the literature, for people who are entering into treatment, you might see people with dependence in older studies. When you see dependence in older studies, like DSM-4 or even DSM-3 revised, it's fairly similar. There are details that you could go to other sessions in this meeting about to see why it's not exactly similar, but it's fairly similar to moderate to severe alcohol use disorder. So just know that when you're looking back in the literature. So we're concerned with unhealthy alcohol use, and there are different ways, in addition to knowing how to define a disorder, which I'll mention, there are different ways to define risky use. But one way to do that is to look at quantity and frequency. And so down here at the bottom of the slide, I've put in what NIAAA defines as unhealthy alcohol use, the at-risk drinking by quantity and frequency. So more than 14 drinks on average per week for men, more than 4 on any one occasion for women, for men, and then more than 7 per week for women on average, more than 3 on any occasion for women as well. So either these weekly amounts or these per occasion amounts indicate risky use. Why? Because most people who have 5 or more, or for a woman 4 or more drinks at a time, will experience intoxication, and then something can happen. You can trip and fall, you can have injury, and so for those amounts, they're the risk for acute consequences. For the weekly amounts, if you're over those on a regular basis, then you risk the more chronic consequences of alcohol. And here's how, in clinical practice, we might ask this question, and this is from the NIAAA Clinician's Guide. You might just ask this one question: how many times in the past year have you had 5 or more drinks in a day, or for a woman, 4 or more drinks in a day? And that's a screening test. It's a test, it's a screening test, just like you might have a screening test for breast cancer or colon cancer. It doesn't mean that you have unhealthy alcohol use, although if you have had those amounts at least once, by definition, you've exceeded a threshold. It's a screening test. And when asking that question, you probably want to keep in mind the size of the drink, because some people may misinterpret what you're asking them. And so this is not the drink that we're asking about when you ask about 4 or more. 5 or more, there are standards. So it's 12 ounces of standard beer, for example, standard strength beer, all the way over to 1.5 ounces of 80 proof spirits, and about 3 to 4 ounces of 5 ounces of regular table wine. If you do go to a restaurant, by the way, and you ask for a martini, the usual martini served in a restaurant is somewhere between 2 and 3 standard drinks. If you have one martini, the usual pour of table wine is going to be a little bit bigger than this as well, so just keep that in mind. Now, so I talked about risky use or hazardous use, and then there's the definition of alcohol disorder. And as was discussed briefly, was it yesterday morning, in the plenary session, the only way we can diagnose alcohol use disorder, or they were talking about addiction yesterday, is by its consequences, which is a little bit strange because we don't diagnose diabetes by having an amputation or by losing your vision or by having kidney failure. That's not how we do it. We diagnose it with a biochemical test, actually, and look for a biological derangement. Well, this is how we diagnose alcohol use disorder. You have to meet these consequences or behavioral criteria. And there they are. There are 11 of them. You can look it up. But basically, it's that you're not fulfilling your role in your life. You're drinking when it's potentially hazardous. You have social or interpersonal problems, tolerance or withdrawal, so these are physical dependence criteria, that you're drinking more than you really wanted to or for longer. You've tried to cut back and you haven't been able to. You spend a lot of time drinking. You've given up activities as a result. You're drinking, continuing to drink despite the fact that you've had some physical or psychological problems, and you experience craving. So if you have 2 or more of those, it's a mild disorder. If you have 6 or more, it's a severe disorder, and there's a spectrum in between. Now, what do we do? And this is now getting into the, well, let me go back. So how do I know that you might need something, that you might need some help of any kind? And that is if you fall into that bucket of unhealthy alcohol use. But there was a range there, right? There are some people who are just exceeding the risky amounts, and there are other people who might have a severe disorder. And if you look for that in clinical practice, you'll find people all across that spectrum. And so the first thing I would do is ask people if it's okay to talk to them about their drinking. Is it okay if we talk about your alcohol use? And then give them some specific feedback, something that they told you, either about how much they're drinking that might have exceeded a threshold, or you might have the result of a screening test, the result of the answer to that question. You might have a blood test that suggests that they're drinking too much. Or you might already know about some consequences that they've had of their drinking that they've told you about. So I might say something like, you're drinking more than is safe for your health. And then I'll ask them if it's okay to give them some advice. Could I give you some advice? My best medical opinion, my best medical advice is that you cut down or quit. Something fairly straightforward. But follow that up with, what do you think about that? Is that something you've ever thought of? Is it something you might be interested in doing, a change you might make? Let me help you set a goal. And then come back and talk to me a few weeks later. So this is what we might do in a general health setting. We might do it once. We might do it next time as well. We might repeat it over and over. So in primary care general health settings, I might have a preventive conversation with somebody if they're not drinking too much, to let them know what it means to drink too much. And I might want to be preventing progression to an alcohol use disorder with a brief intervention or brief counseling, which is a term probably more familiar to primary care clinicians. Do brief counseling in that primary care setting like I just described and demonstrated for you. If they have something more severe, I may know it from that moment if I assessed those 11 criteria, or it may become obvious to me over time, and then I might deliver treatment right there in a general health care setting. What could I do? I could prescribe medications that you're going to hear about in just a few minutes. Or I could do brief, repeated counseling, for which admittedly there's a little bit less evidence, but many of us think that that's ultimately going to be helpful. And I want to integrate their care for this, just like I might integrate their care for depression, for diabetes, for high blood pressure, for asthma. I want to talk to them about their alcohol drinking as well in the primary care setting so that they can get all of that taken care of in one place. I will tell them, though, or offer them some other options, talk about what they might be interested in, see what their interest is in seeking either self or mutual help, which you'll hear about later today. Maybe if it's beyond my capability as a generalist clinician, I might seek help from a consultant, like an addiction medicine or addiction psychiatry physician. And then for some people, they might need a specialty treatment program, and you'll hear about those. So the people at the higher end of severity are going to need more help, but to the extent that I can get them started in a general health setting, that makes some sense. And I'll point out just on this slide in the last bullet here that of referrals to specialty treatment programs, fewer than 7% of them come from physicians and hospitals. So 93% of referrals to specialty treatment programs come from somewhere else. Criminal justice, people themselves, families, etc. So certainly in general healthcare settings, we could do a little bit better than that. Now, how well does this work? So as George said, some of us have spent decades in doing this, so I'm summarizing decades of work here from many people around the world. But brief counseling reduces self-reported risky drinking by about 12%, and it may reduce some of the consequences of drinking too much. Treatment reduces consumption and consequences, this is for people with the disorder, in 2/3 of those with a disorder, and 1/3 are abstinent or drinking low-risk amounts without consequences. That's about a year later. So there is effectiveness to even brief counseling and then to treatment for those who need it. So to conclude and summarize, unhealthy alcohol use includes just risky use all the way through to severe disorder. It can be identified by amounts, but also severity is determined by those behaviors and consequences. Brief counseling, especially repeated, can help reduce use. Self and mutual help and attention to comorbidities, which I didn't talk about, can help. Treatment with medications, behavioral therapies, other specialized services can be effective. And all of the above are needed or helpful when unhealthy use continues and doesn't respond to those initial attempts. Thank you very much.
Anita, could you pull up the next one for me? Thanks. So we are going to keep the questions to the end. And our next speaker is Carrie Wilkins from the Center for Motivation and Change, New York City. Carrie was one of the participants and speakers on the film Risky Drinking yesterday. And she's going to talk about what kinds of behavioral treatments are delivered in treatment programs. So we're going to start drilling down, and Anita's almost there.
Sorry, it's a super strange mouse.
While she's pulling up my slides, just so I kind of have a sense of who's in the audience, how many provide direct clinical services to clients? So I have a ballpark? Okay, that's helpful. Okay, so just a little background. I've been a clinician in this field for coming on 18 years now, and my partner was doing it for 25 years, and we started a practice in New York City. And so from our inception, we've only been using evidence-based treatment approaches, which are what I'm going to be describing today. And I got into this field because as a psychologist, one of my first jobs was in a traditional treatment program, and I was quite horrified and shocked, quite frankly, about what was being said to the clients, how they were being treated. It was a detox and a rehab, and I just was like, what planet did I just land on? So I've been in the field trying to change the culture and trying to change and get treatment programs to pick up these evidence-based treatments, because there's a number of treatments that are really effective, and traditional treatment programs just have not picked them up. Dissemination has been slow, and there's a lot of ideologically based problems in the field that contribute to them not being used. So there's been a couple meta-analyses that have been done on effective treatment approaches, and so, you know, it's the horse race. Who wins that horse race? These are the ones that come out on the top. Community reinforcement approach, which I'm going to talk about more, is a very comprehensive CBT approach. Brief interventions, which were just described in detail, so I'm going to skip over those. Motivational enhancement, which I'll talk about in a little bit. Skills training, behavioral marital therapy, and then acamprosate, naltrexone, and antabuse. I put those on even though they're not behavioral interventions, they're psychopharmacology, just to drive home the point that, again, these are not necessarily being used in treatment on the ground. I included that more recent study in 2012, 14,000 treatment programs were reviewed, and 25% of them only offer one of these medications, and only 5% offer all four to their clients. So again, that's pretty low utilization of really effective treatment options. The worst performing approaches, so these are the ones that fell to the bottom of the list, educational approaches and general alcoholism counseling. So even though Dr. Koob, I'm sure, gave a really good lecture to those treatment programs, the evidence is that those lectures actually are not so helpful. Clients find them engaging and interesting, but in terms of actually instigating long-term change, those one-time kind of lectures are not particularly effective. Don't take that first. General psychotherapy is not so helpful. And I'm going to talk about this more, but confrontational counseling. So again, one of the things that disturbed me so much when I got into the field was just this very confrontational approach that was being taken with people with substance use problems. I'm going to talk more about the research around that. I still use this quote by Bill Miller. It's 2003. It's a really old quote, but unfortunately it is still true. Things are changing a little bit, but it's just so you have the landscape of the treatment field, it's been true for a long time. The negative correlation between scientific evidence and treatment as usual remains striking and could hardly be larger if one intentionally constructed treatment programs for those approaches with the least evidence of efficacy. You like that quote, right? And it's interesting, one of the things that I do, I make myself do this about every 2 years, just because I'm hoping the field changes. I have research assistants in my program call about 20 programs and say, hey, can you send me your weekly schedule? Like, what do clients do when they're with you? Just to see what they're doing. And unfortunately, they really are still, a lot of them, very based in kind of doing a lot of this non-structured stuff. I'm also just gonna, because we talked about it a little yesterday with the HBO, somebody brought up the good point about stigma. One of the main reasons why people don't seek treatment is because of stigma in our culture, which is everywhere. It's in the media, it's how people talk to each other, it's about how people talk to the problem. Again, I think that's changing a little bit. But everybody's heard these things. You need to use tough love. He won't change until he bottoms out. There's nothing you can do. All addicts are the same. Just as recently this week, I had a psychologist call me, and she was very well intentioned, and she called me to refer a family to our program, and she said, "Yeah, he was a 24-year-old kid. He's a terrible addict, and the mom's a codependent." I was like, "I have no idea what you just told me. I'm happy to speak with them, but I don't really know what you're telling me." So the research in terms of what we actually know about helping, so these are embedded in the interventions I'm going to tell you about. So again, confrontation we know actually negatively affects emotion. Bill Miller has and I'm happy to email it to anybody who wants it, does a really nice historical review of confrontation in this field and on the research about confrontation. And there's two things to make note of, which is confrontation actually predicts treatment dropout. And in one study, a single confrontation by a therapist predicted relapse down the road. So not so helpful, and again, used all the time. Motivation comes and goes. It takes a long time for people to decide to change. They're really into it one day. The next day, something happens in their environment or internally that causes them to be like, maybe I don't want to do this today. You've got to be able to roll with that. Motivation increases dramatically in interactions with other people. And therapists are other people. We can have a huge impact on a client's motivation, and we can teach family members to have an impact on their loved one's motivation. Giving people options means more buy-in. When I started in this field, a lot of people just heard, go to meetings, go to rehab, go to IOP, right? Those were the recommendations made to people with substance use problems. The reality is people they develop this problem for lots of different ways, and they get out of this problem in lots of different ways. And the reality is a lot of people get better without ever seeking treatment. So there's all sorts of ways you can talk about this to give people hope that there's options for them. Labels don't help. I say this all the time. I have never once in my career called somebody an alcoholic. It's not a word I use, and it's an unnecessary one. And again, it's a reason why people don't seek treatment. Self-identifying yourself as an alcoholic because you're a part of a self-help community that brings you to that community, that's very different than being told you're an alcoholic. So, and then co-occurring issues have to be addressed, especially PTSD and anxiety disorders. So before I get to those behavioral interventions, just a note about MI, motivational interviewing, because I really feel like you can't teach, it's very difficult to teach people coping skills and get them to accept learning new behaviors if their motivation isn't engaged. Motivational interviewing has been studied in hundreds and hundreds of studies across different problems, different medical conditions, and it's really effective in engaging people in treatment, reducing drug and alcohol use, helping people get invested in making behavioral changes around health problems and treatment compliance. So to sprinkle a little MI in things always helps. So these are the behavioral approaches that are common in addiction treatment. And again, I was just talking to Bob. A lot of treatment programs have figured out that they need to say they do this stuff in order to sell their treatment programs because the public is getting a little bit more educated. Especially in private pay programs, they're not particularly mandated to pick this stuff up, and the training is pretty minimal. If you scratch the surface, people will say, yeah, we do CBT, we do all this stuff, but when you ask okay, what level of training are your clinicians, how are they supervised? For our therapists, for being trained in MI, they have to submit tapes to us for an entire year before we say, yeah, you're good at MI. So, and that's true for a lot of these approaches. And, lack of resources and lack of funding contributes to difficulty doing this. So community reinforcement approach is a CBT approach that really helps people understand the idea that around reinforcement. People don't do drugs and alcohol because they're crazy. They do drugs and alcohol because they work. They have an effect that they like. It feels good. It works for them in some area of their life. So from a behavioral perspective, you work to unpack that with them and really help them understand the triggers, the people, the places, the things, the ways in their life that it's become embedded. And then really figure out, okay, how can we teach you a variety of coping skills so that you don't need to rely on alcohol, other substances as well, in the ways that you do. So you're helping them understand the sequence of behavior around the substance use choices, but the nice thing about community reinforcement approach, and one of the reasons why I think it's most effective, is it expands that out and really helps them with all areas of their life. So it works on their relationship to work, their peers, their family members, their mental health, their physical health. And the idea being, if you can build those areas of their life up so that they're more reinforcing, they're going to be less likely to turn back to their substance of choice. And it's one of the most effective treatment strategies out there. And when I give lectures to clinicians, I'm like, who knows about CRA? And there's usually like 2 people in the audience. So contingency management is based on the idea that people like treats. Human beings like to be rewarded for behavior that we engage in. These studies about CM are mostly around stimulants and opiates. I don't know the percentage, this is just around alcohol, but it's rewarding people for negative urines, treatment attendance. Like for our intensive program that's full of young adults, if every young adult comes to the program over the course of the week and we get perfect attendance, they get pizza. Simple as that is, it's actually really rewarding and meaningful to those kids. Systematic desensitization and cue exposure treatment. So those have a lot of overlap with CBT approaches to anxiety disorder treatment. And so you help your clients rank order in a hierarchy the things that they imagine being really difficult to do sober. Say their goal is to be sober from alcohol. You rank order degree of difficulty of, okay, I cannot imagine going on a first date, or I can't imagine going to that football game, or whatever it is that I can't imagine doing sober. You rank order that and start with the easiest and work to the most difficult to help them in systematic desensitization. You're helping them through imaginal exposures really think through how would I approach this situation. You're teaching them relaxation skills. You're teaching them ways to manage their craving states, drink refusal skills. So there's a lot of skills built into doing those imaginals with clients. And cue exposure treatment is actually exposing them to the trigger itself. So you might be having them smell vodka if vodka's their drug of choice, alcohol of choice. So you're really like bringing them in direct contact with their craving states and then teaching them skills to manage. Interpersonal skills training. A lot of substance using clients have difficulty in their interpersonal relationships. They're a bit impoverished or full of conflict they can't resolve. A lot of people have trauma histories. So helping them do better in their relationships with human beings tends to be helpful in trying to help them pull away from their relationship with alcohol. Relapse prevention is embedded in all those ones that I just discussed. Dialectical behavioral therapy is a behavioral therapy originally designed for people with mood disorders and borderline personality disorder. In the last decade, they've been working on one for substance use disorders that has been found to be effective, and that really tackles 4 areas: interpersonal effectiveness. I got 2 more minutes, I'm cranking through this is my last slide. Interpersonal effectiveness, distress tolerance, affect regulation. So it's really helping them manage the mood states that are often underneath substance use problems. And acceptance and commitment therapy, a lot of overlap with everything else, but that really tries to help people not need to avoid whatever it is that they're feeling that makes them want to drink. It helps them be able to approach that and accept it and tolerate it and act in accordance to their values. And then behavioral marital therapy, Barbara McCrady's been wandering around here. She's the queen and developer of that. And it really, again, focuses on the fact that your relationships can be a trigger and they can also be a resource. So helping the spouse really become engaged in a different way and practice skills. And just that relationship improving. So those are all ways that we try to tackle this problem from a behavioral perspective. Thank you.
Carrie, thank you. That was really comprehensive and excellent. Our next speaker is Dr. Barbara Mason, who's a professor at the Scripps Research Institute in La Jolla, California, and was actually the person who led the charge for the approval of acamprosate by the FDA in the United States. So, Barbara.
Thanks, Anita. I'm sorry. Okay, so I have a fairly concise list of medications to choose from. There are 3 FDA-approved medications for the treatment of alcohol use disorder in the U.S., disulfiram, acamprosate, and naltrexone. And they all share the following characteristics. Not a single one of these is a cure for alcohol use disorder. It's a tool in the toolbox that you can consider using in the right circumstances with an appropriate patient. None of them are alcohol substitution drugs the way methadone, for example, is for heroin. None of them are addictive or habit-forming. You don't need increasing amounts of the drug to have the desired effect. When you stop the drug, you don't have a rebound of craving or drinking. They have negligible street value if you tried to sell any one of them. And none of them are associated with euphoria. All of them should be prescribed in conjunction with an appropriate form of counseling, which Carrie laid out beautifully. And all of them have better drinking outcomes with counseling than placebo with counseling. They all have efficacy that's greater if you start from an initial position of abstinence of at least 4 to 7 days duration. But despite the incremental gain in efficacy, they are prescribed for fewer than 9% of Americans with alcohol use disorder based on a nationwide pharmacy survey. Carrie's data based on treatment settings is even more ominous in terms of, how little access patients have to these medications that may give them an incremental gain in the likelihood of recovery. The first medication I'm going to talk about is disulfiram. Its original brand name was Antabuse, although it's available now in generics. It was also the first FDA-approved drug in 1951, so it's been around a while. And its mechanism is the alcohol-disulfiram interaction. When you take disulfiram, it changes the metabolic profile of alcohol so that acetaldehyde builds up very quickly, while simultaneously you have a rapid onset of flushing, nausea, palpitations, and other cardiac symptoms. You can have mental status changes, and in some cases of severe reactions, you can actually have death. And rather than its pharmacodynamic properties, it's really a psychological deterrent to alcohol use, because you don't want to have this alcohol-disulfiram interaction. In general, medication compliance tends to be poor if you just give a prescription to an individual and tell them, take this once a day in the morning. But if it's given under conditions of supervised administration, whether by a spouse or a clinic, the outcomes are much more favorable, particularly, obviously, in patients who are compliant and motivated to be abstinent. You must start with abstinence with disulfiram, or you will have the alcohol-disulfiram interaction. It should never be given to someone who's in a state of intoxication or without their full knowledge, because the interaction will be induced by alcohol-based aftershaves, desserts with Grand Marnier in them. The very slight trace amounts of alcohol can induce the reaction, so people should be aware. It does have a warning for hepatotoxicity, so you should obtain baseline and follow-up liver function tests, which can be obtained at LabCorp. And in some cases, it can induce drowsiness, so people should be advised to know how the drug affects them in terms of their ability to drive or operate heavy machinery before they perform those tasks. The maintenance dose for most people is 250 milligrams daily, taken in the morning, and it costs about $18 a month. The next drug I want to talk about is the next drug approved in the US in 1994, Naltrexone, whose original brand name for the oral formulation was Revia, but it also is available in generics at a cost of about $27 a month for one 50 milligram tablet taken by mouth a day. It is a pure opioid receptor antagonist that was originally approved in 1984 for the treatment of opioid dependence. Heroin binds to the mu receptor, as does naltrexone. Alcohol is a very promiscuous drug in terms of its receptor binding, but the mu receptor is a key element of the reward system. So the hypothesis is that with alcohol, if you block the mu receptor, you'll experience less rewarding effects of drinking. And if drinking is less pleasurable, the motivation to drink will decrease. Meta-analyses have shown that naltrexone significantly increases the rate of no heavy drinking, as Rich defined it. 4 more drinks a day for women, 5 or more drinks a day for men. The FDA considers this a very important outcome for clinical trials because it is associated with health consequences. And naltrexone met that marker compared to placebo. NNT refers to a measure of effect size. It stands for number needed to treat. And what this number tells you is that about 9 people need to be treated with naltrexone to receive that perfect outcome of absolutely no heavy drinking for, the days of treatment. But of course, people have, a day here or there, and still represents a benefit from their baseline drinking. Compliance problems have been noted with the oral daily dosing, and so Vivitrol was developed, which is given once a month as an extended release intramuscular injection. It was approved in 2006. It's hard to believe it's over 10 years old already. The current cost is $1,372 a month for an injection, but it does take that daily dosing off the table. It should not be given, neither the oral nor the injectable, to patients with current prescribed or illicit opioid use, as it will induce acute opioid withdrawal. In fact, the side effects that we see with naltrexone represent a mild endogenous opioid withdrawal, little nausea, headache, But if people are using opiate-based cough medicine, pain relief, or are abusing opiates, and they're given naltrexone, they will experience acute withdrawal. The FDA recently removed the warning for hepatotoxicity for naltrexone, but the data are there that in some persons there's a vulnerability to hepatocellular injury with naltrexone. So again, it makes sense to have baseline liver function tests and repeat them with treatment. Acamprosate, brand name Camprol, was FDA approved in 2004. It costs about $108 a month. The pictures that I've been showing you are the front and the back of the pill, but this one is a good reminder that acamprosate is 2 pills taken 3 times a day because it has low bioavailability, and you want to cover the whole period of vulnerability to drinking and craving. And I have 2 suggestions. Put the pills in one of those over-the-counter pill dispensers that indicate the day and time of day that a dose should be taken. And my other suggestion is to remind people that they're renewing their commitment to abstinence with every dose they take and make it part of the treatment and motivation. So how does acamprosate work? It's a little less clear than blocking or making you sick, heavy drinking and withdrawal repeatedly, and those chronic cycles dysregulate the balance between excitation and inhibition in the brain, predominantly the glutamate system and the GABAergic systems in the brain. And what acamprosate does is it brings these systems back to a normal level of functioning, particularly at the NMDA receptor in the glutamate system. And it has been shown to increase rates of abstinence in studies of up to 1 year in duration. And its number needed to treat in meta-analyses is 7.5. So you need about 8 patients to achieve the magic outcome of not a single drink, but people have gains along a continuum with the drug. It is not metabolized in the liver, unlike the other 2 drugs, which is a real benefit for people with alcohol use disorder, because the liver is an organ that's very vulnerable to the harmful effects of alcohol. Instead, it's excreted through the kidneys, which are not commonly affected by alcohol. But nonetheless, if patients have impaired renal functioning, you should refer to the package insert for dose adjustments or use a different treatment option. And it is safe in patients with liver disease, even those pending transplant. So, that's an important option. So, it's a question like, when should we use medication? How should we use it? Which medication should we use? And as Rich suggested, you might consider medication, especially if there's an inadequate response to counseling. And if you are considering it and you haven't used it before, you might want to review the package insert. It's also called the drug label. It has all the FDA-approved information about a drug: fair, balanced, benefits, risks, harms, and the NIAA's Clinicians Guide that you can access online provides very accessible forms of information. But also, talking with a respected colleague who's used medication is very helpful. We always invite an expert in to talk about their experience with a drug before we use it in our setting. So then you have the confidence in terms of your understanding of the drug to talk about the pros and cons with the patient, keeping in mind their health status, whether they have compromised liver function, their motivation to be abstinent. If they don't have motivation to be abstinent, they are not a candidate for disulfiram. If they do, acamprosate might be a good option in terms of helping them to sustain that outcome. And then ask them, after you've described the pros and cons, well, what feels right to you? Which one do you prefer? Because if you have the patient signing on board, then that's often something that affects their response and the outcome of the treatment. And then in the case of inadequate response with a medication, you might consider using one of the other medications. Or if there's like a partial response, maybe they've reduced their drinking 50% from their pre-treatment levels, but they really need to do better, but aren't getting there, you might consider adding on a second medication. For example, disulfiram was added on to acamprosate in a large multi-site trial and showed a benefit over acamprosate alone, which showed a benefit over placebo. And in Germany, the combination of naltrexone and acamprosate showed a benefit over the individual meds, which showed a benefit over placebo. That's Falk-Kiefer's trial. But large trials did not replicate that finding. The differences between treatment conditions washed out. And then if a person seems to have an established recovery, but then relapses, and this happens sometimes after many years of recovery, if they've done well in the past on a medication, restart it without hesitation. The patient is likely to sign on with that if you remind them that despite their current situation, they have done well in the past with X, Y, and Z, and let's give it another go, because relapse is part of recovery. You just have to keep on trying, resuming treatment. So those are my comments. I've given my slides to NIAAA, so please don't hesitate to ask Bob or Anita if you would like a copy, and thank you both for including me.
Thank you, Barbara. As Mark Twain said, it's easy to stop smoking. I've done it 20 times. So our next speaker is Kim Johnson. She's the director of the Center for Substance Abuse Treatment at the, let me see if I can spell out your acronym. It's SAMHSA, but it's Substance Abuse Mental Health Services Administration. I am so proud of that. Anyway, Kim, it's all yours.
Yeah, I mess it up a lot myself too, so. Thanks. So I have a set of data that I'm going to share that comes from 3 sources, and if you get the slides, all the sources are listed in the slides, and then hopefully I'll have time to tell a story that I think really explains what the treatment system is like from a patient perspective. So this is where people get services, and the top line is it's about 1.6%, this is over the past 10 years, about 1.6% of the adult population receives services for any substance use disorder. This isn't just alcohol use disorder. Do I have a pointer? Oh, this right here. Where's the right there? Oh, that right there. This line is self-help. So the majority of what people call treatment, of what people get that they call treatment, is self-help, is AA or other self-help groups. And this is outpatient treatment. And underneath is the rest. So another way of looking at it is if you take out the self-help, then about 89% of people that get specialty care get it in an outpatient setting. So I think a lot of people have this image of res rehab, you see it on TV, celebrity rehab, but most people that's not where they get their care. Now these aren't mutually exclusive. People can get care in at multiple sites and at multiple levels, but just to point out that most people are receiving services in outpatient care, and there has not been much change in the past 10 years, although the one that is growing a little bit, this is methadone treatment programs, OTPs. And that's growing a little bit, and that's because we have we have basically doubled the number of people in this country that have an opioid use disorder in that time frame. Now this is not an easy to read slide, and I apologize for the graphs, but it's really important. So the length of stay, this first graph is outpatient treatment, and this is residential treatment. So remember, this is what most people get. You can't really talk about the average length of stay, can you? Because it's really bimodal. This is one unit. And this is actually the single most common unit, because when we get up here beyond 30 days, these are groups of days, like 30 to 45, 45 to 60. So the most common occurrence for people that enter treatment is they get one service. So what is that one service? It's a comprehensive biopsychosocial assessment. So they don't actually get any treatment. They go in and they get asked a lot of questions, way more than Dr. Sates talked about asking in order to be able to diagnose. They get asked a lot of questions, an hour, 2 hours. And when I ran a treatment program, we had one particular assessment that was for women that were involved with child welfare that was 4 hours. And they never come back, because why would you? Right? If that's all you get is that comprehensive assessment. And we, government, are somewhat responsible for that, because one of the reasons you get asked all those questions is because of our voracious data needs, so that I can give you slides like this. So we're actually looking at how can we reduce that expectation. The other thing basically what happens in outpatient is you either get almost nothing or you get quite a bit of services. It's really bimodal. The thing that I want to point out, and I will talk about a little bit later, is we don't count zero. And I think if we counted zero, that would be the most common occurrence, is people call, they get an appointment scheduled, and they never actually get to that appointment. But we don't have a way of capturing that data, so what you ask is important, because we're missing that very important point. Residential looks a little different, because your biopsychosocial assessment has probably been done up here in an outpatient setting, and so when you get to residential, you're actually being admitted to the program. And can you tell what this one is? It's 28 days. So when you are in residential treatment, it is just like celebrity rehab. You get your 28 days of care. That's the most common occurrence. Who pays for it? Substance use disorder treatment is primarily a publicly funded service. 69% is paid with public dollars, as compared to regular health care, which is about split in half between public and private. And who pays for it is kind of interesting, and this has not, my next slide will show that this has not changed in about 30 years. It was slightly different in the 80s, but since about 1990, it hasn't really changed. So federal dollars, this is mostly the federal block grant. State and local, this is primarily grant dollars. Medicaid pays about 21%, private insurance only about 18%, Medicare very little. If we were looking at, I probably should put this up, a chart of what the general health system looked like. Medicare would be a huge part of it. It's a very small part of this treatment system. And this is the system over time. This is actually since the first bar there is from 1986. So in the 80s, insurance paid a lot bigger percentage than they do now, but since the early 90s, there's been very little change. This almost blank spot that has changed over that time is other federal. That's primarily the federal block grant, and the reason it hasn't changed is because the dollar amount has been relatively stable, so the percentage, as the cost of treatment has gone up, the percentage has been shrinking over time. So I don't know, that may be a surprise to you. I think people look at healthcare in general, look at the changes we made over the recent past, and think that may have changed how the distribution of funding for addiction treatment, but it has not. And again, this is the spending, but it looks pretty much like the other charts that I showed before. The money mostly goes to outpatient. Again, this starts in '86. So we see a sharp decrease in hospitalization. That's as insurance got out of it. And if you've worked in this field long enough, you remember when there used to be 28-day programs in hospitals. That moved to residential care. But it's been relatively stable for the past 20 years plus in terms of the distribution of spending. So you have heard what the services people get once they get into treatment. I will say it's kind of funny, if you look at the survey that we do on treatment programs, about at least 85% of the programs say they do all of the things on the list, which is probably not physically possible. But I think they really do believe that they offer that, although if you ask the clinicians themselves, as opposed to the administrators, what they're offering, that they'll have a different answer. But we don't necessarily ask that question. So who provides the services? Some of this may seem obvious, and some of it may be a surprise. And this is the counselors primarily, the direct service staff in our treatment program. About 67% are female, 64% are white. This one surprised me. 56% are under the age of 45, so they're not old. I've had the impression that they're all middle-aged and old, but that's not true for direct service staff. 29% are in recovery, so fewer than I thought. 39% have a master's degree or higher level of education, and 24% have a bachelor's degree, so it leaves about 30% that have nothing higher than a high school education. or an associate's degree, I guess that falls in that category too. 55% have been in their current position for fewer than 5 years. And here's one that I think is interesting when you think about behavioral therapies. 70% have a caseload of fewer than 30 patients. So actually a very manageable caseload. When I ran a treatment program, that was sort of the minimum that I thought was allowable for my staff to be considered having a full caseload, because you don't necessarily see them every single week even. So that's the data. But I want to talk about a patient. I mean, she's not my patient, but a woman who has been trying to get services. Because that, as I said with the kind of ugly chart, the most common unit of service is 1, and if we actually collected the data, the most common unit would probably be 0. So I've been communicating with this relatively young woman since about March. She's a mother. I think she's in her late 20s, early 30s. She's actually, she has co-occurring disorders. She has an opioid use disorder and an anxiety disorder. Actually, a very relatively hard combination to treat effectively. She feels that she was effectively treated by a medical provider that gave her buprenorphine and an anxiolytic, I forget what it is, Valium or something, that was a benzodiazepine. And I'm telling you all this from her perspective. She's reporting this to me. Her physician kicked her out of treatment because he got something either from an insurer or from some external organization that recommended that he not provide that combination of medications to a patient. And so from her perspective, what he did was kick her out of treatment. So she relapsed, and she started seeking treatment. And she lives in a rural area, small town, in a relatively poor state. But she's not homeless, so she's housed, has some resources, and so she seeks treatment in her community. There's a community mental health center, and she goes through the treatment program, and they say, well, we can't give you what you want, because she knows what she wants, right? She wants buprenorphine and a benzodiazepine. That's what she wants. She knows it works for her. So she contacts everybody, the state, the federal government, and I have been interacting with her periodically over this time, but she can't get into treatments, and we can't figure out what the problem is, and of course we're all blaming her. So an appointment was made 10 days after that initial contact. She didn't show up. What she says is, something came up with her daughter. She has a 4-year-old daughter, and I have been a parent of a 4-year-old. Those things do happen. But we all blamed her, right? It was her fault that she didn't show up for the appointment, and people kind of resented that she was asking again. So on a Sunday morning, she reached out to me, and I happened to be on my computer at a conference like this, and so I picked up the phone and called the 800 number for the state emergency crisis line, and I had a busy signal. And it was busy for 20 minutes, and then I finally got a person who then said, well, she's not in this county, I can't help you. Try this other number. Call the other number. I didn't get a busy signal, but I got a person who said, well, that's not this county, try this other number. Tried another number. Got a message that said, please enter your PIN code. Well, at this point, I've lost her. She's gone. I don't know where she is. We're communicating via email. She's gone. So that was that experience. She reached out again, and it was on a work day. I finally actually got a hold of someone at the state government who said, was irritated about the whole process and how we keep getting them involved again, and said, we tried and we did what we could. But she can go to this community mental health center. And so I passed this information on to this woman. She says, are we talking about the same place? Because every time I contact them, they say they don't provide medication-assisted treatment. And I said, well, their website says they do, and the state says they do. But I figured I'll call them myself. So I call, and I say who I am, which I thought might have some influence, but it didn't. And the person that answered the phone said, well, we can give her counseling, but we don't have medication here. And I said, well, what do you do if someone needs medication? And she said, well, we send them to this place an hour and a half away. And so I get back to the state, and I said, they don't offer medication there. And the state says, well, yes, they do. And I said, well, I just called myself. And they said they don't. So then a VP at the organization gets in touch with me and says, well, yes, we do. And I said, well, how? Because she's been trying all this time. I initiated the contact between the two of them. That's the last I've heard from her. I'm hoping that they actually figured out how to get her something in the community that she's in. But this is not an unusual story. This is sort of a typical experience. I have dozens and dozens of these stories that I could share with you about the experience of trying to get into care. And so what's the experience of treatment? Well, the experience is I'm really lucky to have gotten it. That's the experience of treatment, regardless of what happens there. So I think that's all I'll say about that. Thanks.
Thank you, Kim. That was super and gives us a real-life vision of what we're up against. So our last speaker, and then we'll open it up for questions, is Keith Humphreys. Where are you, Keith? There he is. Keith and I were in the rowboat together of the Surgeon General's report, which created a further bonding in our careers. I think there were 10,000 critiques to that report. Isn't that what Tom said? Anyway, Keith had to deal with all of them. I ignored them. All right. So he's going to talk about what role do mutual help groups play in the treatment of alcohol use disorder. Keith.
Thanks, George. Okay.
Oh, I forgot to say, I'm sorry, he's a professor in the Department of Psychiatry at the Stanford Medical Centers in Stanford, California.
Thanks, George. Hi, everybody. I was going to talk about all mutual help groups, but because we're going to try to keep the talks short, I'm just going to focus on the biggest and the most important, which is Alcoholics Anonymous. If you want to learn about the many other options that are out there, I wrote a book about 15 years ago called Circles of Recovery, which you can probably find for cheap online, or you could call my mom. I think she bought the copy that sold. So I learned about AA first time 30 years ago, and I started to feel someone asked me what I thought of it. I didn't know what it was. I thought, is that the people who jump the car battery in the winter, or what is that? But I found there's this thing, Alcoholics Anonymous. In fact, I was working on an addiction research project, and they were a member of that organization on it. And they told me a little about it, and my first reaction was that this sounds a little hokey, sounds a little folky. I don't see any medical involvement. I'm kind of skeptical. So if that's your reaction, I don't blame you. I had the same reaction. But over the ensuing decades, there's been a lot of really good science done, supported mainly by NIAAA, but also by the VA and other organizations, that we can now say there actually is a lot of good evidence about it. I'll tell you a little bit about that. And it should be taken seriously. When people call me, as they call all of us, asking about how to get help for a drinking problem, I talk about all the things that have been said in these excellent presentations, but I also always say, you may want to try AA. It does, in fact, help a lot of people. Okay, so let's go here. So it's a 12-step organization. You know that term. It's in the lingo of the popular culture. So all those organizations like Narcotics Anonymous, and Overeaters Anonymous, and Marijuana Anonymous, whatever, they are all spin-offs of Alcoholics Anonymous. So it's the first one, 12 steps. 12 steps is a program of action that they invented that people would take. It's non-professional and peer-run. There's no psychiatrist, there's no psychologist, there's no social work. It is run by the members themselves. It was founded in 1934 in Akron, Ohio. I just actually was in Akron, got to see one of the founders' houses. It's a national park monument now. It has only one purpose: to help alcoholics become sober. Now, two words in there deserve comment. I just said the word alcoholic. I would not ever say that in treatment. We talk about people with alcohol use disorders. But in AA, it's an identity. You are an alcoholic. You don't have alcoholism, you are an alcoholic, and they use that word. Second, I didn't say abstinent, I said sober. In AA, the goal is to become sober, which means abstinent, you don't drink anymore, but it also means lots of other changes in your life and in your outlook and your spirituality, so that you are in a state of serenity and well-being, and you treat other people well. That's sobriety. So it's not just they don't want you to drink, but you got to do more than that. And this is the sole purpose of AA. So some people wonder, why doesn't AA crusade against drunk driving? Why don't they ask for higher taxes on alcohol? Why don't they advocate for more treatment or whatever? It's like, because this is the one thing they do. They decided, we're just going to have this thing. It's our sole purpose. And whenever they're asked to do something, they go back to, is this consistent with our sole purpose to help alcoholics get sober? That's what they do. It's been an incredibly successful organization in terms of its growth. I mean, one of the most successful of the 20th century. 2 members in 1934, 50,000 members in 1950. Today on the planet, probably about 5 million. And I would say probably at least in 190 countries. Probably very few that don't have an AA meeting somewhere. Structurally, it doesn't cost anything. You know, you put like $1 in the hat or something, but you don't have to pay anything. You don't need any health insurance. You don't fill out any forms. You don't make appointments. You just show up. There's no length of stay. You can go as long as you want, and it's widely available. And this is, I think, is part of the genius of the organization. So imagine you live where I live, and it's Saturday morning, and you're having your 50th hangover of the year. And you're having a moment of insight of like, wow, I've got this great job in the tech industry, and I have this, you know, I live in this multi-million-dollar one-bedroom condo, and I have a lot to lose, and I think I have a drink problem. I'm going to get some help. I'm going to call those smart people at Stanford. So you call them on Saturday morning, and you will get a warm, compassionate message on the machine saying, call back on Monday. Of course, when you call back on Monday, we will immediately and promptly put you on a waiting list. So in contrast, you could go to an AA meeting that morning. You would just go on to the website, and all around the area there is it. In fact, you can even say, I only want to go to a non-smoking meeting. I only want to go to a women's meeting. I only want to go to a meeting that focuses on prayer and meditation. It's all there for you. And so in that sense, it's really well matched to this condition where people are ambivalent about change. I want to change, and then I don't, and then I do. You can just go right now, instantly in. And so that's part of, I think, the very wise part of the structure. And of course it's a wise structure. It was made by people who had the problem, so they kind of knew what the market was. What does AA really do? Well, the best way to learn this is to go look yourself. So the most important thing to know is AA holds meetings all over the country, and they have a distinction. They're open and closed meetings. Closed meetings are for people who have a sincere desire to stop drinking today. Open meetings are for anyone, including us, who wants to learn about AA. So I've been to lots of open AA meetings. I've been to them all over the world. And they want to educate people about what they do. So that's the best way, not listening to people. Actually just go to some and you can see. You can also go, if you're a loved one, you have maybe someone who's in AA, you wonder what are they going through, or you just want to understand or whatever. Students can go. I always make the residents make sure they go see one of these things. In the meetings, you'll see people sitting around, sometimes in a circle, sometimes the way we're sitting with a speaker, offering each other, sharing their experience, strength, and hope of what they've gone through with alcohol and how they're trying to rebuild a new life of recovery. Meetings are there's always some kind of opening at the beginning. Maybe they read from an inspirational book, or someone says something, a prayer or some kind of meditation. And then they welcome newcomers. It's very important to them to acknowledge new people, and they try to be particularly encouraging to them, like after the meeting, keep coming back and so on. And then sometimes it's a discussion, like they'll say, we're all going to talk this week about resentment. How do we deal with resentment? Or sometimes it's a speaker. So someone come in and they'll actually tell their whole story. Here's what I was like, here's what happened, here's what I'm like now, which kind of ends with, and now I'm in AA, and here are the things that are going well for me, and here's how I've prospered, and so on. And they made this up as a technique on purpose. They say this flat out in that book, which is called The Big Book, is that they were hoping it would hook people. People would say, oh boy, that person is a lot like they used to be like me, and now they're doing well. How can I do well? And that's exactly why that book has all kinds of different stories, young people, old people, men, women, people in different occupations, because they were thinking, we're going to basically throw a lot of bread along the water here, and we're going to catch you this way. The storytelling is really important. You also hear a lot of practical advice that would not sound out of place in a psychotherapy session. They just use different language for it. So they'd say, fake it until you make it. Whereas I would say, behavioral practice will produce mood congruent cognitions and emotions. Because, the way I say it trips off the tongue so much more easily than their sort of clunky formulation of it, and so on. But a lot of stuff they say, that, stinking thinking, are things, I don't use that language, but I would also talk to patients the way that, they help people learn about how do you think, how do you act, what are the avoid slippery places, people, and things. Well, I say let's look at your cues for use and how to keep away from it. So it's a lot of stuff that you would find very, very sensible. It's not a discussion in the meeting. In other words, people don't talk to each other. They don't comment on each other. It's like serial monologue. And that was so you don't criticize people or anything like that. However, they do have a thing called sponsorship, where a newer member will pair up with a more experienced member, and they'll meet privately, and the sponsor can say is allowed to comment directly on what the person says. For example, you're blaming you say your marriage has been bad for 20 years, it's 100% your wife's fault. That seems ludicrous to me. Let's look at how you are contributing to this problem. That's okay to say that, but you would never do that in a meeting. Okay. Oh yeah, and they have literature, like the big book is one, 12-Step and 12 Traditions. It's all free. They're perpetually broke by design. They do not accrue money, but they do take the donations and they basically use it to print literature, which they give away. So they just kind of have just enough money to function, and they actually very consciously, the founders thought, if we had a bunch of money, something bad would happen. So we're not trying to become a rich organization, and they're not. You would also meet people in AA who are coming directly into AA as their first thing. You would also meet a lot of people came through treatment, or through they saw somebody like a Rich, a primary care doctor recommended, or maybe they saw someone like Carrie coming out of a treatment program. There's lots of pathways in, and no real right or wrong way. So it's really popular. It's the most popular way people try to recover from alcohol problems in our country. That does not mean that it works, okay? In the early part of the 20th century, there was this pill, Carter's Little Liver Pills. Maybe your grandmother took them, okay? They were very, very popular. Your dad took them, okay? Very popular. Then the FDA looked at them and said, these are inert. They have no effect on the liver. So the company said, okay, they just relabeled them Carter's Little Pills. And they were still very, very popular, but they were inert. They did not do anything. So the fact that all these people go to AA and all these people like it does not prove that it works. And that is what the science has really homed in on, I would say, particularly in the last 25 years, since NIAAA sponsored a really important conference in '93 that produced a nice book, Researching Alcoholics Anonymous, edited by Bill Miller and Barbara McCready. What was known was summarized, but also was like, we need to actually find out if this works. And so a lot of nice studies, Project Match and so on, have been done on that. The critical problem we always had is, how do you deal with self-selection, right? Because anybody can show up to AA anytime they feel like. We can't control it. It's not like a surgical procedure. And so the way they did that was to develop something you could randomize around, which is a form of counseling called 12-Step Facilitation Counseling. You can get the manual from this right on the NIAAA website for free. So with studies like that, a lot of things have been done. And just recently, working with Todd Wagner, who's an economist, we took all these together and used a procedure called instrumental variables modeling, which economics developed right when it broke away from necromancy and it became more of a respectable magic. And taking the 6 NIAAA trials, 2,300 patients, and you look and say, like, let's look at this in randomized studies. The part of AA that is truly attributable to randomization, not the self-selection, does that help people get better? In the 5 of the 6 trials it did. They drank less. So that's the reference for that paper, but you can also read, my friend Austin Frack wrote this up for New York Times, a nice treatment on AA and evidence-based medicine, and you can see that there if you want. So yes, it does really work. So, conclusion, first off, Alcoholics Anonymous is a very popular, long-standing, peer-led resource for problem drinkers. We're lucky that we have it. I love that we have treatment. I want people to get treatment. There will never be enough treatment for everybody, and frankly, not everyone needs it. There are a ton of people who go straight into AA and they do fine, and that's good because it's not like we need more work to do or we have so much money we don't know what to do with it in the treatment system. It offers meetings. It offers sponsorship, that one-on-one relationship. It offers a lot of helpful behavioral strategies, advice, life change advice strategies. Because remember, the goal is sobriety, a full recovery, not just stopping drinking, but changing your life, changing your perspective, changing how you treat people, changing how you live. And on average benefit, what it looks like, it's about as good as the really good outpatient psychotherapies that have been developed by scientists, by psychologists, by psychiatrists, and so on. So that doesn't work for everyone, but cognitive behavioral therapy doesn't work for everyone either. But if you look at the mean effect sizes for motivational enhancement, cognitive behavioral therapy, and AA, they're about the same. So I'm as comfortable suggesting people try that as I am suggesting they come to the clinic and try what we have to offer. So anyway, I'll just leave it there and be interested in your questions. Thank you.
So everyone, I have to go out and make a phone call. It's not to my broker, it's for NIH. And so I'm going to turn this over to the panel, and they're going to be able to answer any questions you have. Maybe, Trish, could you come up and just pretend you're me and encourage questions? But please step up to the microphones if you have questions. This is a real opportunity to find out if things that maybe they didn't cover or you want more emphasis on. So.
Hi there. Thank you so much. My name's Seema Cliffasefi from the University of Washington. Great presentation, very informative, and I really look forward to getting the slides. Rich, I wanted to ask you a little bit about your thoughts, and maybe other people on the panel. You mentioned at the beginning of your talk this hierarchy, almost this one-to-one correspondence of the more you use, the more negative consequences you experience. And I kind of wanted to challenge that a little bit, because we all know there's exceptions to this rule. So there may be someone, say, from the dominant privileged class who may drink a lot but not suffer many negative consequences, versus someone, say, from a marginalized population where a little bit of alcohol use might have large negative consequences. And then even more extreme and sort of paradoxically, thinking about someone who's severely dependent, for whom abstinence is actually maybe a life-threatening thing as well, with delirium tremens. So I just kind of wanted to get your thoughts, and maybe the other panel members' thoughts on this kind of one-to-one consequences, to maybe get us to think as a field about how we can personalize and tailor treatments specifically for the individual, rather than this kind of overarching model. So I wondered what people's thoughts were about that.
Sure, thanks for that question. I think there are other examples of what you're talking about. For example, people who are elderly can run into trouble with very small amounts of alcohol. So there's no question about that. There's even risky drinking that is under the limits that I told you about. So drinking during pregnancy is one example of that. Drinking while taking a medication that interacts with alcohol could be less than those limits that I told you about. I think overall, the more you drink and the more often you drink, is a fairly good relationship with the consequences. But no question that it's a sort of monolithic way of looking at it. And when treating or addressing this with individual people, you might want to pay attention to individual circumstances. I wouldn't go so far as to characterize abstinence in anyone as dangerous or harmful. There are ways to get there safely, and we can prevent delirium tremens, and we can treat delirium tremens, and delirium tremens is rare. So I wouldn't quite say that, but there are times when people can certainly cut down and do well and don't necessarily have to abstain. There's that whole spectrum. The real point was that there's a very large spectrum of unhealthy alcohol use, and this is actually perhaps to your point, that within that very large spectrum, there are folks with different levels of risk and characteristics, and we should pay attention to that. I do not have to rely on the moderator.
So I was just thinking, for the population that I work with people who are experiencing homelessness and severe alcohol use disorders, the kindling effect, so the number of times they go through detox, actually increases their mortality rate to the nth degree. So I guess I just wanted to get us to think about different kind of harm reduction approaches as well, and include that in our various models. So thank you.
I will make one comment just about the treatment system in general for different populations like you're talking about. One of the things that I think is lacking in lots of outpatient programs, and this idea that you have to go to rehab in order to get better, is childcare. And a lot of people don't have nannies and babysitters and after-school programs and things like that, and you got to figure out what to do with your kids. So being able to provide childcare while the person is in treatment, I think, would capture a lot more people in need.
Just to get at the socio-demographic issues that you raise, it would be great, any of you that are, is it not on? I'll lean in. Does that work? Yeah. If you can find the biomarker, it would be great. I think that's, I talk to payers and they say, just give me the one thing that changes that we can measure. And so if you all could figure that out, those of us that do health services research and that are actually trying to implement systems, it's complicated when you have to use these kind of outcomes to actually create the diagnosis.
Okay, so we have a charge to the research community. Next.
It's great talks from the panelists. I believe prevention is an important part of treatment. So what are the available programs, prevention programs from AAA, or how AAA is promoting the prevention programs, especially for the adolescents who are from families with alcoholism history? Thank you.
I'll take part of that. NIAAA has a whole division on prevention, so we have a lot of research on it. We also have screening guides for both clinicians, for both adults and adolescents. You know, one of the ways to encourage prevention is to catch people early, to get them when they're before they've developed a disorder, but when they're at risk for developing a disorder. So also support a large amount of research in various settings, from schools, juvenile justice, families. I would encourage you to talk to folks from our department, a division of prevention research, but also to look on our website. We have a lot of materials available.
Just quickly, we actually, with alcohol, have been very successful with prevention with adolescents in particular. And so a chart that I frequently show, didn't make sense to show in this presentation, but is the rate of alcohol use and rate of alcohol use disorder in adolescents, and over the past 15 to 20 years has come down. It's cut in half, over half. And the rate of alcohol use disorder for young adults kind of follows that, right? So use goes down with adolescents, and the rate of alcohol use disorder is going down with young adults. Now, what it leaves is the high-risk folks that you're talking about, and I think in terms of what we have actually implemented out in the world, we've done pretty good with primary prevention that's universal, and addressing the needs for people who are high risk is sort of the next stage that we need to do better at.
And just one follow-up on that, Dr. Koob mentioned what we call extreme binge drinking in his opening remarks as well. And we have a new initiative looking at drinking to blackout. It seems to be, rather than seen as a problem, it's seen by those who are doing it as an aim, and we're trying to figure out why that is and what we can do to prevent it.
Just one quick comment on that is that there are bigger ways to do prevention than programs that we've just mentioned, and those are things that happen in society, like drinking age and taxes.
Next.
Hi, Brandon Bergman from the Recovery Research Institute at Mass General Hospital. I'm actually a clinical psychologist and a clinical researcher, but I wasn't going to miss an opportunity to hear you guys all talk about your respective areas of expertise. And so my question is directed, I guess, more for Keith, although I think everybody might have a chance or some insights around this. All the different services you all talked about, whether it was psychosocial treatments, medication, having your disorder managed in primary care, or mutual help, they're not necessarily mutually exclusive, as you guys all talked about, right? Somebody could be getting multiple services at the same time. And oftentimes they are, right? With mutual help and medications, though, especially, there's always been sort of a funky relationship over the past several decades, and I think there are two separate, it's even different when you talk about AA and medications for alcohol use disorder as opposed to Narcotics Anonymous, NA, and medications for opioid use disorder, so we can sort of save that second piece for another time. But, and I know folks have done research on attitudes about medications in AA, but I guess I was really just wondering what your thoughts were on the intersection potentially of mutual help and medications. Can those two things coexist together? And again, so I was thinking about Keith when I had this question in mind, but certainly if anybody else has insights, I'd be happy to hear them.
Okay, so thanks for the question. I mean, it is certainly true there's members of 12-step communities who do not like medication. It is also certainly true that there are many people on the street who don't like medication. I mean, methadone, I think if you survey 100 Americans, you can get at least 90 nasty comments about methadone. So they exist in the culture that they're in. They have changed a lot, I have to say. It's a lot different than when I started my career. I think when you would have been afraid to mention being on an antidepressant in an AA meeting, which is not the case anymore. But it still does come up. What I suggest is, look at AA has a statement on this. They say don't play a doctor. You're not a doctor. So you can always say to someone you're working with, if someone in AA told you AA says you can't do this, you can say no, that is not what AA says. This is the hospital, that's the AA meeting, this is where you get your medical advice, not from there. Doesn't stop it from being hurtful, doesn't stop some people probably go off the medication when they shouldn't, so those are real problems. Also, like I said, I didn't have time to get them, there are other organizations, Smart Recovery, Life Ring, Women for Sobriety, that have never had that feeling about medications. That's another option for people.
So we'll take a question from the front.
Thanks very much. John Saunders, Sydney, Australia. I'm a physician. in addiction medicine. I guess this symposium is part of the broader effort to try and help basic scientists and clinicians understand each other's work. So I've got a rhetorical question. What are the intellectual and human characteristics of science, basic science? What are the intellectual and human characteristics of clinical work? And what are the intellectual and human characteristics of self-help? You don't have to ask that. I did say it's rhetorical, but I'd like to sow a seed of thought in your minds.
I'll just say one quick thing about the clinical basic divide. And I also, by the way, co-lead a neuroscience collaborative, so I think about this a lot when I'm working with card-carrying neuroscientists, is in a huge amount of clinical work, as in the huge amount of people solving their lives, the reasons don't matter, the outcomes do. So I can't figure out why this particular patient isn't drinking more, and who cares, because he's happy, his family's happy, and everything is totally Jake. But for basic science, they want to know mechanism. And that's else why do science, and so that when I look in the collaborative and I see the discussions, that's often around that issue. What should be, who needs to know what's going on as long as we can fix things, and then the basic people say we have to know fundamentally what the reality is. So for example, we could have a biomarker, for example, and who's right? They both are.
Let's go back to the back.
Fall Glow of NIAAA. I want to thank the panel for this great presentation of all the treatment approaches. I was wondering if somebody could comment on the sort of idea of treatment algorithms and what to treat first and how to treat first and what to do if you don't respond to the first line of treatment. And as we're moving into evidence-based medicine, are there treatment algorithms? And if they're not, why not?
Do you want to answer? Yeah, why do you want to go? They're a great idea.
Okay. Thank you for the question, Falk. I think with regard to medication, it's really important to get the patient sign-on after a neutral discussion of the pros and cons and health rule-outs. So that kind of precludes a hard and fast algorithm, but you can like I had suggested, that if you have a partial response, you can try adding on one of the other two medications. If you have no response, you might consider switching entirely to an alternative. But other algorithms, and also in our setting, we do motivational interviewing to help people set an abstinent date that will coincide with the onset of medication, and then we switch over to a more cognitive behavioral form. And I'm also very interested in other techniques as well, like ACT, which is son of cognitive behavioral.
Yeah, I don't know about any hard and fast algorithms either, but I do think good addiction treatment providers really do have multiple decision trees that they're, those 2-hour assessments she was talking about, you're going over timelines of like their use. What does it look like now? What does it look like in the past? What are the behavioral learning curves that have happened over time? What are underlying issues that need to be addressed? What's happening in their environment? So there's so many different little pieces of the puzzle that you're trying to rejigger with the client, and your point of you've got to get buy-in constantly of making these changes still matter to you, and why? Is it worth the effort? So there's just, I don't know about an algorithm, but I think to actually be really thoughtful about what you're pursuing at the time you're pursuing it, and whether or not the client's engaged with that or not, or whether you're just making recommendations that they're tuning out in response to.
I mean, I too was going to refer to Kim's reference to the assessments. And what happens in those assessments is extensive. And then no matter what the result of the assessment, the person gets the same thing. Yeah. And that's really, that's the worst thing that could come out of the assessment, right, is that you've spent all this time and then you get the same treatment, and what you get is what's available, right? Not necessarily something that matches you. So I think, but the reason that there's not algorithms, I think, one big reason is that most of the studies of treatments are 3 months, maybe 6 months, some are a year, and they don't change them over time. So we don't have a whole lot of evidence to support various different algorithms. So what we do in clinical practice is we usually try something and we choose things for practical reasons, not necessarily matching to clinical status. And then we add things and change things over time. It's not algorithm based on evidence.
So we're coming to the end of this session. I see 4 people standing. If the panel is willing to stay and address those. But I would ask that people make their question concise, and if you want to go first.
Well, I'll give it a try. I'm a clinician and a researcher at the same time, and most of the time it helps me to do both things, but sometimes it gives me problems with staying asleep or falling asleep. And here's the example. As a researcher, I'm able to set up some kind of way to assess the outcome of what I'm doing in research project. When I'm looking at outcomes of my clinical work, the situation is much more difficult, and for reasons which are very clear and well described today, because we have to meet people at different stages of their readiness. We have to apply individualized treatment approaches, and to combine all of this into one set of outcomes is very difficult. So my question for the panel is there any effort to approach this problem and set up more or less formal set of ways to collect outcomes for at least some of our treatment approaches? We hear that by the end of first year after treatment, it is 20% of people who will remain sober. Then we hear it's only 12%. And when we're trying to find actual evidence, which we did, we were not able to find any evidence which would support it. And this is for as clear outcome, if anything is clear in our work, as abstinence. So,
who wants to take a first stab at that?
A quick answer is just there are systematic reviews of treatments, and you can find the treatment effects in those. And the second issue is that there are lots of different ways to measure things that aren't just abstinence, quality of life. For 30 years we've had the Addiction Severity Index. There are other similar tools. So I think there are tools that are used in clinical practice to measure that.
Yeah. But I would just add, I don't think there's anything wrong with measuring abstinence or reduction in use. I mean, it's a reasonable outcome to measure and have that be your primary measurement of the outcome.
Well, my question is that there is no evidence to show what is the average outcome in the United States.
There are samples. You can look at lots of different samples, but it does go to variability in samples, and you can also look in randomized trials that look at those outcomes.
So you're interested in population level measures for your caseload as opposed to individual. Yeah, so we are actually working on that. I have a study going on now that's looking at an insured population, Medicaid and private insured, which is a specific population, but I have data for it, so it's forthcoming.
I think in the interest of time, we'll take another question, and if you all have time for a separate conversation, you may want to pursue that. We'll go to the person in the back.
Thank you. First of all, I want to acknowledge it's a really hard challenge to take 30 years of experience and give it in 20 minutes. My name is Scott Tonigan. I worked with Bill Miller 25 years. I did the analysis on many of the studies he reported on MI. I've worked as a co-investigator with Bob Myers and Jane Smith on CRA. I was a co-investigator on Match, Combine, REP. My question is, let me reframe it. Is 12-step facilitation an evidence-based treatment? And why was it completely ignored in your presentation?
Yeah, it's funny. I made those slides based on that meta-analysis, and it is an evidence-based treatment. And it was my oversight when he had that slide up. I was like, I should have put that back on there.
I would hope that you would, in the future, redo that, because really, it's the most dominant model in the United States. And actually, if you look at the data, it is equally as effective and actually superior on days to first drink and absolute abstinence at 1 year.
Yep.
So I think what it reflects, not intentionally, is that how many clinical psych programs teach 12-step facilitation? How many teach the ones you have? All
Very
of them
few.
teach the ones you have.
Right.
The one that's community-based is ignored.
No, and part of the problem was I had it in my head. I'm supposed to talk about behavioral interventions, so that's what that slide was based on. Not so much. And then I'm constantly talking about EBTs, So, and I agree. Right. I know, and you're right in terms of how we were trained. It's not. I don't necessarily think about it in the same way as exposure-based treatments. It's more in the relapse prevention, cognitive behavioral, like in my mindset around it. So. I agree, and I will fix the slide.
And it was nicely covered in its own talk as well. We're going to do one last question.
This is a brief comment. In my opinion, this panel would make a great HBO special.
And with that, I want to say I think it was great that we had the HBO Risky Drinking film yesterday. This was a beautiful, approachable, engaging set of presentations that were very informative, especially to those who aren't intimately involved in the treatment. So let's take the opportunity to thank the panel. And even though Dr. Koob is back, I'm going to do a channeling of him and do a shameless plug for NIAAA. We're coming out soon with the Treatment Navigator. So you've seen a little bit about the treatment system. The Treatment Navigator helps you work your way through that, and I think it's going to be a very valuable resource. Thank you to Anita and Bob for organizing. Thanks again to the panelists.